I was in Nicaragua and realizing this country that had made a lot of investment in socialized healthcare, a lot of community health workers, but very few surgeons or operating rooms had the opportunity to be a model of pushing this sort of care forward. Thanks to some of the great relationships with Operation Smile, found us at dinner one night with President Daniel Ortega. And that became a 4-hour conversation that in 2 a.m, when Operation Smile and the Nicaraguan Ministry of Health and their government said, we want to launch this together, President Ortega turned to Bill McGee, the president of Operation Smile, and said, well, who's going to come and lead it? And of course, Bill, without talking to me beforehand, looked over at me and said, well, he is.
Welcome back to the DIEP End. Today, we're joined by Dr. Jordan Swanson, a pediatric plastic surgeon and craniofacial surgeon at the Children's Hospital of Philadelphia and the University of Penn. Dr. Swanson's path is anything but conventional. From studying international development at the London School of Economics to working at McKinsey, and then moving his family to Nicaragua to help build a cleft surgery center with Operation Smile. Now at CHOP, he directs one of the nation's leading cleft and craniofacial programs, pioneering innovations in pediatric surgery, gender-affirming care, and global surgical education. We've got a conversation filled with courage, empathy, and what it really means to push the field forward. Let's dive in. Welcome everybody to another episode of the DIEP End. This is a very special episode. We are obviously not in our normal format. We're here at the Figs store in Philadelphia on Walnut Street. I want to thank Figs for partnering with us for this episode. They're really a part of the community in Philadelphia, and 1 in 6 physicians, I actually recently learned, had some sort of training in Philadelphia. So it makes sense that one of their only 2 stores is here, right, in Philadelphia. And our guest today, obviously, thank you for being here, Dr. Swanson. Not that far away, all the way from CHOP, one of our plastic surgeons there. Do you want to give us a little introduction about yourself?
Thanks, Hank. It's great to be here with you and Saїd, obviously, 2 people that I look up to and enjoy having as colleagues. I want to just add my shout out to Figs as well. I, as you can see, am not in any Figs wear as you handsome guys are right now. I do not own any, not yet any. But one thing I think is cool about Figs is that Philly is, as you mentioned, kind of a healthcare city. Yeah. More than that, healthcare is cool here. And I think in a lot of cities that I've lived in before, people in healthcare, doctors, nurses, clinicians, maybe they're second-class citizens compared to finance or tech or whatever. And here, it's a lot of pride in it. You see people walking with their head high. South Street Bridge every day across the Schuylkill River. You see hundreds of people coming and going across it to Fittler Square Graduate Hospital where they live. And it's super cool. And a lot of people are wearing Figs, I've noticed. So I think it's all part of that kind of yin and yang. I think it's really cool.
Yeah, I love that. I think that's one of the reasons why this makes this episode so special. Like you said, this isn't our typical setting, but knowing that this is one of 2 Fig stores makes this really, really awesome for us.
And usually where we like to start, obviously you've accomplished so much, and we'll hit all those things as the episode rolls. But to get our guests to really know you at a deeper level, we really like to start all the way kind of from the beginning and just what was growing up was like, what brought you into medicine, and what brings you to where you are today.
Thanks. Big question. Yeah. Well, so I grew up near Seattle, Washington, in Puget Sound on a small island. I grew up kind of building forts in the woods and playing with Legos, the things that people on kind of rural islands tend to do, like the tree house. Built a couple of those, it seems, as child and his father now. One of the big influences on me was my grandfather, my mom's dad. He was a Marine that fought in World War II, but early on he was picked to do language training. And in addition to, storming the beaches as Guam was, taken back, he also did a lot of work with Japanese prisoners of war and work on relations with them. Then was in Japan and Tokyo and actually had a lot of relationships with Japanese families that he got to know during the war. And I got to know some of those families when I was a kid. And all 4 of his kids, including my mom, all spent some of their young adulthood living overseas. In Liberia and in Honduras. So I spent some time on a model farm that my aunt was running in Honduras. And, it didn't strike me as a sentiment of charity so much as just, global citizenry. We don't know where we're going to be born. When I was in college, I took this great class on justice. And this philosopher, John Rawls, said, when you make a decision, think behind this veil of innocence of which side you might be on when you find out what your role is. And I think it's kind of a model where we don't know who we're going to be. So in any interaction, think about the person on the other side.
Yeah. And was there anyone in your life that was in medicine, or when did you stumble upon that?
Very few. I kind of spent a lot of time in the outdoors as a kid, and mountain climbing. We'd sometimes come across people that were in need and hurt. And I found actually wilderness medicine really interesting. How do you kind of improvise with little material, stabilize people, figure out what they need? And that actually kind of became my interest in public health early on in low and middle income countries, in similar settings where there's maybe less resources than what we're used to. How do you kind of solve for that and get to know people in those conditions? And that really is where my interest in medicine began.
Yeah. So you went to a really small college, Harvard. Growing up, did you ever say to yourself, I want to go to Harvard? How did that happen? That's extremely difficult. And so tell me a little bit about how that came about.
A big jump for me was when I was 14, I stopped going to school on this little island and I went to school in Seattle. I took the ferry every day back and forth, and it was like the big city. And it was so eye-opening. Things I'd always heard about from, say TV shows like delivery pizza and cable TV, which I'd never experienced. Suddenly I saw this and I thought, this is really cool. And so one thing that's been a little pattern for life is I've actually, even though I see myself as a little bit of a country bumpkin, I think that amazing cities are truly terrific. And that's one of the things I thought was really cool about Harvard.
Yeah. And then tell me a little bit about how, like, what the experience was like there. I've visited there a couple of times. It just seems so like inspiring. You walk somewhere, you go to the coffee shop, and it just seems like you get ideas everywhere you walk. I can't even imagine going to undergrad there.
It was a neat place. I mean, I think everybody's college experience is cool. And right here at Penn, I think there's a similar kind of intellectual energy. One of the things that was really special for me is just there were opportunities for young people. I, early on, for whatever reason, thought history of science was really interesting. It was a tiny little division, and undergrads could do a thesis there. And I learned a lot about kind of the history of medicine, and that really deepened my interest. I also bumped into the office hours of this economist named Jeffrey Sachs, who was really big with international development then. I didn't know much about it, but he really kindly took me under his wing. I did some research with him. And he enabled a lot of my summer experiences kind of on his behalf, working in a lot of overseas places to really understand how economics and health can work together. If you can grow, an economy, how that makes health better. But also if you make people healthier, that's going to drive a better economy.
Yeah, it's so impactful, like these little people in your lives that just help guide you on the right path.
And it's funny because I think a common theme we see in a lot of our guests is the path isn't always straight. We have this path and we come across different interesting things, and everyone's so fascinating. I'm sure there were a bunch of turns and twists, and you didn't just end up where you are today. Can you tell us a little bit about some either setbacks or unconventional paths? Yeah.
So I went from college to medical school at Hopkins, and I had a great experience there. It was pretty old school in the teaching. We would, take call overnight in-house. They would sometimes send the intern home. You would hold the pager, not something that's done today. Yeah. You would write orders. That was all, pencil orders, and they had to be co-signed within 48 hours, which is certainly not how Epic works now. Yeah. But it was tough. I remember one night, after being in the hospital overnight, the next afternoon I was going home. I lived in Federal Hill, beautiful spot, sunny spring afternoon, and I'm just getting home and my pager goes off, my beeper. It's the chief resident, and he said, we're doing a liver transplant on a 3-year-old tonight. I'd love if you scrub in on the case with me and the attending. And so, of course, you take a shower and go back in. And long about 3 a.m, long about hour 45 of being up. Student. Yeah, I started getting kind of sleepy. And the case I realized now was not going very well. And the questions became more pimping questions. And it was kind of tense. And I think that was one of my realizations that, we sometimes need to be a little less intense with how we kind of teach and mentor sometimes. Yeah.
And then, but you did have somewhat of an unconventional path to medicine. So tell us about that.
So I took 2 years off in the middle of medical school. And these are some of the 2 best years that I spent.
Were you allowed to do that?
It was not typically done, but the dean was really kind and supportive. I was really enjoying clinical medicine, but I also really wanted to learn about how healthcare could really impact people in lower resource settings. So I spent 1 year studying an international development degree at the London School of Economics. And I also spent a year working in business. I worked as an associate with McKinsey and Company, the consulting firm. And during that time, I thought maybe I would migrate away from clinical medicine to business, the business of medicine. Maybe that's the way I can be more impactful, is through business. And it was a terrific experience. I worked with some really bright people, and a couple of those people now, one leads Novartis, One leads Tenet Healthcare, which is one of the largest hospital systems in the country. They were both really bright people, but I really missed the clinical medicine. And the boardroom was exciting. You know, you make some big decisions and look through some PowerPoints together and allocate some funds. But I missed actually the patient-to-patient interactions. So I turned around and went back, not only to finish medical school, but with a really renewed interest in clinical medicine.
Yeah, and then what sparked the plastic surgery interest? That's most important.
And then the craniofacial interest.
Well, if you're listening, Donnie Buck was one of my medical school classmates, and he found plastic surgery. I was looking at maybe pediatric surgery. I love doing things with my hands, but didn't quite know the fit. And Donnie did a rotation in plastic surgery, and he said, hey, Jordan, you know, plastic surgery, they're doing some really cool pediatric stuff. Craniofacial, it's a lot of reconstruction. And I see this cleft lip and palate stuff they're doing has a lot of global health. You should check it out. I met Dr. Rick Redette, who was a tremendous cleft surgeon at that time. Dr. Eduardo Rodriguez was the chief at Shock Trauma. He took me under his wing, and Dr. Paul Manson, who was the chief of plastics at the time, who I still think of as three of my original mentors in plastic surgery, and all really took a leap. I was this kind of unconventional guy that had gone away. They really kindly leaned into kind of what I've been up to, and I'm still very grateful to all of them.
Yeah, you know, I trained at Hopkins for general surgery. You know this, but when you name the people like Redette, Rodriguez, Paul Manson, I mean, what better people to be surrounded by to be so inspired to do plastic surgery?
And it almost feels full circle with how you grew up, and now like the global health and, you know, reaching back out to the community was where you kind of found your roots back and into plastic surgery. I want to also talk about how obviously you trained plastic surgery at UW, and then you did a craniofacial fellowship at CHOP, and you decided to stay at CHOP. What makes CHOP so special, and why did you want to stay here in Philadelphia?
CHOP's a neat place. So pediatric plastic surgery is special. Some people just resent the idea of having to interact with parents. They'll say, oh, there's not one patient in the room, there's three. It can be that way sometimes. I actually love families. I love kids. I find it so energizing. And yet children's healthcare, plastic surgery has to be really cautious around kids. It has to be precise. When I do a lip repair in a 3-month-old, I'm not really going to know the result for another 15 or 18 years. So understandably, plastic surgeons and pediatrics are cautious. CHOP is special because it's, I think, one of the rare places that is precise and cautious, but also works to push the envelope and innovate. And I think part of that is you have a great history of surgeons here that have invested in residents and fellows, train them early, train them to be precise and do these cases so they have a better, bigger team around them when it comes to the really tough cases. And the spirit of innovation stretches to families. Obviously, a lot of people come from around the country to be part of this. It's very special. So it's this high octane energy that I've never seen anywhere else.
Yeah, and the legacy obviously is unmatched. One of our first guests was Dr. Whitaker, actually. And obviously the Center for Human Appearance has been great to us and supported us as well, which he started. What does Dr. Whitaker mean to craniofacial plastic surgery, and also what did he mean to you?
He's still a very special person in my life. And I met him when I was a fellow, even when I interviewed as a fellow. He and my wife are both from Texas, which endeared them to each other right off the bat. The tall tales began and have never really stopped. He and I share a lot of, passions, travel, skiing, things like that. One of the things that I actually am most proud of in my life right now is holding the Linton Whitaker Endowed Chair. And that's an incredible honor to me because I know the legend that that's named for. And Linton was an innovator in craniofacial surgery, but it came from his curiosity. He loved to travel. He was really interested in people. He was a very broad-minded person. He loved teaming up with people in different places to learn. He would go to present his complications. And a lot of early travel clubs started with groups that found trust in sharing their vulnerable moments, which is really cool. But the thing that above all is special about Dr. Whitaker is his courage. Because as I mentioned, it's hard to innovate with children. And I say that in a theoretical sense. I've had moments when I'm in the operating room, and I think of one in particular, the first time that I was working on this neo-bandeau procedure to move the back of the skull down to the front of the skull to reconstruct the orbits, which really hadn't been done that way before. And I'd really thought it through. I'd done some practice runs, but doing that on a 9-month-old for the first time, you really feel the risk you're taking, and it requires courage. And when I was in that moment, I was really channeling Linton's model. And I can't imagine the amount of courage in his career starting 50 years ago and really, even with fewer resources than we have today, how he really lived that. So we are so lucky that he's still a part of our program, that he was at graduation a couple of weeks ago. I think he'll be celebrating his 90th birthday next year.
Incredible. That is incredible. Yeah. But what I also love about this story is I'm learning a lot about you. So I'm learning how you like to kind of push your limits with the dean of the School of Medicine at Hopkins and go away for 2 years. But you didn't mention how before you got a job at CHOP, didn't you also go away for a little bit?
I went away for a bit. So, how global health, how people approach global health is a question a lot of students ask me right now. When I was a resident, I actually really kept my head down and really wanted to learn the craft of being a surgeon well. I think there's a balance between pursuing outside interests and focusing to learn a craft. And as much as I think that it's important to problem solve, I also think expertise, that 10,000 hours that my partner, Dr. Bartlett, talks a lot about is so critical. And as I was nearing the end of residency, what was keeping me up at late at night was that I think the level of care in places like Seattle and Philadelphia for children these days is pretty remarkable. It's come a long way. But 80% of the world doesn't have access to this sort of care. And that's troubling to me. And what was really important to me and to my wife was to really spend some time shoulder to shoulder with the people in those settings. I really believe that it's not going to be people in Philadelphia, it's people on the front lines in Managua, Nicaragua, and Casablanca, Morocco, and in rural Ciuna and Bonanza, Nicaragua. They're going to be the ones that are going to be the change makers. And I wanted to learn from them. I had an incredible opportunity as we both spent some time looking with potential partners in Nepal and Ecuador, looking for people that were doing perhaps pediatric cleft surgery, but wanted to partner with a craniofacial surgeon to bring some new things to their country. And I was in Managua, Nicaragua with the group Operation Smile. They had been doing missions there for about 20 years. And they had developed a local team of people, but thought that next year was the year to actually build a center there and really try to create a locally autonomous team, which was really ambitious. It was also the year in 2015 where there was a lot of focus on global health and global surgery. So the WHO, the World Health Assembly of the World Health Organization, drafted really the first ever and only since mandate for doing global surgical care. The Lance Commission for Global Surgery that was chaired by John Mira up in Boston Children's created its really impactful report. And I was in Nicaragua and realizing this country that had made a lot of investment in socialized healthcare, a lot of community health workers, but very few surgeons or operating rooms had the opportunity to be a model of pushing this sort of care forward. And those discussions, again, thanks to some of the great relationships with Operation Smile, found us at dinner one night with President Daniel Ortega. And the next night, when that first night's conversation didn't have enough time, he said, come back, to his palace, and we will talk after dinner. And that became a 4-hour conversation that in 2 a.m, when Operation Smile and the Nicaraguan Ministry of Health and their government said, we want to launch this together, President Ortega turned to Bill McGee, the president of Operation Smile, and said, well, who's going to come and lead it? And of course, Bill, without talking to me beforehand, looked over at me and said, well, he is, which was an incredible opportunity. I moved there with my wife, Magda, and our son, Laz, who was 1 at the time. And in the first couple of months, I was traveling these pretty rural areas, really working to get to know some tremendously talented surgeons there, learn from them and figure out what we could do together. And I first thought, gosh, this would have been easier if I came here as a single guy. And suddenly I realized—
Don't tell your wife.
No, just because it was a hardship for the family.
Of course.
But then what I realized was actually being there with my family made people realize we were there for the right reasons.
That's true.
We were there to be there for a pretty extended period of time. And it really deepened those relationships. So we managed not only to build this center, which became year-round care for children with clefts, but start this program to bring rural surgical care out into more rural areas of Nicaragua and really kind of prove the model of doing that, which was extremely special.
Do you think those 2 years you took in medical school away kind of prepared you to deal with like diplomacy type stuff and all this economics of other countries? And obviously you come from a like CHOP with all these resources to no resources. How are we going to be efficient? How are we going to make this work? Do you think that—
Totally. Two main things that I took from that time. One, from the side of international development, is really the right philosophy for doing it inclusively, understanding that this is about supporting people who should be the ones with autonomy in these settings to use us as foreign visitors in ways that will be helpful to them, but really refrain from setting our agenda. A second side of it was, I'd say, the McKinsey side, and that's how you think about problem solving. Yeah. We as surgeons, it turns out, I think, are not terrific at figuring out kind of how a program runs and how to make things work and be sustainable. And a lot of that problem solving played a big role. I was doing, making PowerPoint decks to sort of try to explain to ministry personnel how we could do this, try to kind of listen to them. Think about telling stories, which is something that, people learn about sort of narratives using visuals. It was an interesting time where a lot of my preconceptions about global surgery also changed a bit. So for instance, I think there's a sense that, say, the medical mission isn't a great model. It's expensive. It involves, displacing potentially local staff. Those are potential risks for sure. But there are also things that were very special about the mission model. For one, a lot of people in these countries are volunteers. They're healthcare workers in their hospitals. There's not funding for them. They can't take off a day a week to do this kind of cleft work. But if they can take a week and there's really a lot of energy and excitement around a joint program, an outreach program, that brings in a lot of local people. Another aspect of that is it's a great way for surgeons to learn from each other. When I finished my training, I've not gotten to do a lot of scrubbing with other attending surgeons. We talk about coaching, which I think is really important. It's hard to actually get that. But when you're for a week in a space that has 4 or 6 operating tables, and you're with surgeons that are reasonably competent and have a humility of, hey, come look over my shoulder. Give me some pointers of things maybe you do differently. Or maybe I might see something and say, hey, I saw this, you might want to think about it. It's an incredible learning curve for kind of, secondary education. And so missions are actually a very special way to do that. There's also limitations to them. And there's other cool models. There's great models of how we actually give bursaries of finance to surgeons to basically pay for surgeons in those places to have the financial incentive to do these surgical cases that aren't being done. However, a risk of that is that it can start to commoditize procedures. And you both know there's a very slippery slope to surgical procedures being commoditized where quality starts to erode. It's about getting the numbers done. And the harm can actually, I think, very quickly add up. And so these are tricky things we got to balance. There's also a mentality of, if a surgeon, say, in North America is not doing a particular case regularly, maybe they shouldn't be practicing in that location or volunteering. I saw one tremendous surgeon from Canada who actually trained with Dr. David Fisher, who's a real pioneer of cleft lip techniques. And he did in phenomenal cleft lip repair and cleft palate repair. And he said he's been doing, 2 missions a year and actually managing to do 30 cleft lip repairs each year through that. And that's really important to him. And so my preconception that shouldn't happen, I realized there's exceptions to rules. And I think that humility is a really important part of the process.
What's funny is hearing you talk about this, you can tell how passionate you are about it, to the point where I could almost imagine you leaving there to come back was probably a little difficult. But hearing you talk about it, I almost wish that there was more of you in our training programs or just around. So what do you think we need to do to educate or train people on global health, global surgery?
I think we need to create opportunities that involve mentorship. And actually, Don Mackay, who was at the Penn State and is a tremendous legend in our field, had made some great progress with the RRC for plastic surgery just before COVID. I think COVID was a bit of a setback as far as some of that momentum. There were a number of twinning programs in existence between academic programs in the U.S. and other places that would try to do bidirectional exchanges. Some of those were slowed down with COVID and have not come back, unfortunately. But that's something that I think is super important because, we have a tremendous resident from Ghana that's with us this week at CHOP. And he's sharing great ideas with us as he's in the operating room with us. And if we could have more continued interaction with programs like that, that's, to me, I think, a model that's terrific. I'm really proud of the fact that right now in CHOP, there's actually about 10 different countries that we're having bidirectional exchanges with. We don't do all of them as consistently as I would like. Dr. Oksana Jackson, one of my dear partners, is getting on a plane tomorrow to Ukraine, where she'll be for 10 days doing surgical procedures, primarily focused on pediatric plastic surgery and cleft. But one of the partners there that does craniofacial surgery and I are now talking by WhatsApp, sort of discussing cases together. We're sending some equipment to them. Hopefully they will be here sometime this year as well. So I think those develop that mutual respect. There's been some tremendous programs. The Plastic Surgery Foundation and the SHARE program has done some great work with both clinical and research work with a number of partners in sub-Saharan Africa. So those partnerships, we need to do more of. It needs to be something that is part of residency programs for those who wish. We did a study about 10 years ago looking at residents that had done an Operation Smile week-long rotation in a mentored and supervised situation. And few of those surgeons had actually gone on to make cleft surgery their primary practice. But if you look at the ACGME competencies and what we're actually trying to teach residents, that group had an outsized growth compared to their peers. Is that because they got that over a week? Is that because people who are going to be fast growers tend to gravitate towards doing work that is focused on vulnerable people? Who knows? But it's something we should clearly be amplifying.
I think that, I mean, you bring up so many good points, and this actually has me thinking that I need to do better about it on my own, you know, and I know Steve Kovac also goes to Ukraine and you don't only have to do this on the pediatric side. You know, that's a common misconception, I think. I think there's always talent needed in those locations.
In many ways, I would say that, you know, there's even more opportunity and wins right in front of us in other spaces because they're newer. I work with a bunch of hand surgeons right now that is trying to do something similar to what has happened with cleft. And I don't do any hand surgery, but I'm in the role of kind of sharing with what has worked and maybe has been a little more difficult with cleft. So we're collaborating with a hospital in Armenia right now that's focused on hand surgery. And as I look at the data for this and help kind of steer some of the opportunities there, I realize, you know, this is probably more of an opportunity than cleft because there's been less effort so far. I totally agree with you.
So I know this because I was a trainee under you. So I have the fortune of seeing you from a trainee perspective, also as an attending. But you're an incredibly busy and productive surgeon, an excellent educator, and a world-class clinician. And you have a busy, busy, busy practice. A lot of it is obviously craniofacial surgery, vaults, cleft lip and palate. You co-direct the cleft lip and palate program at CHOP. Talk a little bit about that part of your practice.
The cleft program?
Yes.
It's tremendous. So the CHOP cleft program was one of the first in the country that really pioneered a multidisciplinary model. Dr. Peter Randall, who was really the spearheader of that,
I've heard so many great things
really lives on as a legend for our program. And even with technology that happens and enhances what we do, and that's also something very much of interest to me, we sit down face-to-face every Thursday afternoon with all the team members and discuss patients. We just did it about 2 hours ago for our craniofacial patients. And it's incredible what I learned from all the other people around the table, just insights into families, kids' needs, and it accelerates this care that we do. What's really neat is we've sort of amplified that cleft program and having a number of different surgeons that are using slightly different techniques, we can really start comparing and find what works better in some circumstances and what not. And I think this is one of the ways we push the field forward. One of the things that's also special about that program is Nurse Nancy Folsom. And she is a beloved nurse, very talented. She became the cleft nurse navigator about 8 years ago. And what's been really neat, she's basically there, phone call away for families, patients, to help them bridge gaps that we all experience. And she's there for everybody. But one of the neat things is we try to figure out how do we mitigate some of the barriers to care for these patients. We see a lot of disparities, unfortunately, in access to cleft care right here in Philadelphia. And one of the things we found is that since the inauguration of Nancy's programs, non-English speaking patients, those who are non-white, and those who have greater barriers as far as poverty and economic challenges have had a far faster reduction in barriers, earlier on-time surgery, faster weight gain before palate repair, all of these things, likely all attributable to her role. So this team has some surgeons involved in it, but the magic is far beyond the surgery.
Yeah. And, you know, we talk a lot, you mentioned this a little bit earlier, that some people avoid pediatric surgery because they want to avoid the parents and the families. And that's such an integral part to being successful in your field. And you do it really, really, really well. And I saw that as a trainee. I'm seeing it as one of your colleagues. What's your philosophy in approaching what you do? Pediatric surgery, craniofacial surgery, but also your interactions with family. And is there any particular scenario or patient interaction that you wanted to share?
And I want to interrupt real quick because I want to add to your question, because I remember something that you always did since I was a medical student. It's resonated with me since I rotated with you in clinic. And this adds to your question, but I always remember you bringing the patient in front of the mirror and looking at it with them so that you can see what they're seeing and that they can see what you're seeing. And I always thought that was incredible. And one of the things that makes like you incredible and how you gain trust with the family, with the parents. I think that's one of the things
So what's your philosophy?
Yeah.
I'm a big believer in kids. Yeah. I think kids are tremendous. Yeah. And I think that a lot of their potential might not yet be reached. And if there's ways that we can help unleash that potential, that's the biggest job that we do. I also have a lot of empathy for their circumstances. I was skiing up at Blue Mountain with our family about a little over a year ago, and my son Joaquin got hit, unfortunately, by an out-of-control snowboarder and fractured his femur. And over the next 8 hours, we found our way to some local hospitals and eventually to CHOP. And he had excellent care, and I was back on the other side of the doctor-patient relationship. And it gives you, again, a reminder about how challenging that is. It might be 30 routine patients in my clinic, and for those families, the bottom has just fallen out. And it's a difficult time. So it starts with that point of empathy. One of the things that I think is really cool that's shaping what we're doing a bit more and more is patient-reported outcomes too. And patient-reported outcomes are cool. It's sort of a buzzword right now. What I think is exciting about them is actually how they change how we practice. And so we've done some studies recently that kind of look at things like how different surgical techniques we use affect patient outcomes. So for instance, we looked at 8 to 10-year-olds who had cleft lip and cleft nasal deformities. And we compared some who had a nasal repair when they were infants, and they had some who had their nasal repair when they were 7-year-olds with their bone grafts. And my hypothesis was, well, the ones who had their nasal repair more recently probably have a better job. It's just a year ago. It hasn't aged a whole lot. So they're going to be way happier with their outcomes because probably objectively look better. And interestingly, it was the opposite. The patients that had it repaired early, who had been able to just grow into that body and hadn't kind of known something else, did much better. And interestingly, we also learned that aesthetically, the early ones tended to do as well or even better than the later ones. So we kind of changed some of these philosophies. It's that data that's going to help us do it. And so that's where it gets exciting, is kind of how you meld the data with the patient experiences and kind of learn carefully as you work.
And you can quickly learn from talking to you that you also do the research program at CHOP. So you're incredibly busy. But, to your point that, we get so, our day is so routine. We see 30 patients in our practice, very busy days. Taking a step back and treating each patient and recognizing that they're coming here with a life-changing event is so incredibly important. And you basically mentioned that, to take a step out of our doctor shell and just treat each patient. They're coming here with a life-changing event. To your point, I think that's incredible. But the other thing I wanted to mention is we're talking a lot about pediatric surgery, but what I want the audience to know is that you also have an adult practice. And you do adult craniofacial trauma surgery at Penn Presbyterian, our trauma center for Penn Medicine, and also gender-affirming care. So can you talk a little bit about that and how you integrate it in your practice?
Yeah, it was very interesting. I never did any gender-affirming surgery as a trainee. But in my first few years in practice here in Philadelphia, I saw a growing number of patients that were seeking this care. And I also realized that as a
Do you remember your first?
Vividly. I remember a lot of my early patients because it was some very frank conversations that I had. I tried to be very honest about the fact that, I don't see myself as a gender surgeon. But as I looked at really those procedures, they overlap so sort of complementarily with the work that I do in cleft lip and palate with craniofacial surgery. It's about aesthetics and function. What's very interesting about gender surgery and especially facial feminization surgery is that, unlike, say, trauma, where we're trying to reconstruct a broken part, unlike pediatric, say, congenital surgery, where we're trying to anticipate growth and restore something that was born differently, unlike even aesthetics, where we're trying to enhance a nose or a face, gender-affirming surgery is actually a radicalization in a fairly different direction than the natural anatomy of that face. And that's actually really interesting. And so one of the things that I've learned as I've carefully studied my results and how patients have perceived them is that I've actually been pushing the envelope more and more with some of the maneuvers that we've been doing. For instance, restoring the cheekbone projection, which is typically done with fat grafting for facelifts, et cetera. What we realized is that actually to reconstruct a female-shaped zygoma in malar region, we really have to get more projection and restore really a bone difference that's probably better done with a bony-like material. And so using porous polyethylene or PEEK implants that are actually quite dramatic tend to create much more feminization, which is really interesting. That wasn't where the thinking was 3 or 5 years ago.
Yeah, and you love this part of your practice. You and I have talked about it before, and it's so nice how you can be so good at what you do on the CHOP side, but also have this aspect of giving back to the adult side as well.
I think it's one of the special things about plastic surgery is that there's so many areas of what we do that are different sides of the same coin. But what I would say is that, I would say I am continue to be a student of what facial dysphoria and gender dysphoria are like for my patients. But it's incredible to observe the incredible reward they feel and the power of what a surgery can do to reduce that dysphoria, to create harmony in their appearance and their self-perception.
Yeah, can you talk about it must be so difficult managing expectations, and it probably makes you a master at that because you kind of have to, defy some of the, what's in their head, put it on paper, and kind of meet them what they're thinking and what you're thinking, what's doable and what will make them happy.
We're actually at a very interesting place, I think, in our field with this, because some of the really interesting technology tools that are coming out that let us visualize things, let us manipulate images, enable more of a visual discussion beforehand. And I think when you're contrasting options for patients, you can kind of set either or type things. When I'm doing a rhinoplasty, I ask my patients, tell me more about the dorsal contour that you're looking for. And I'll sometimes have them bring in photos of noses that they like. And it's really nice when they see something that is probably reasonable for their face, and it prompts some really good discussion when they bring something in that's totally not. But I think there's also been a transition away from this idea that you'll do manipulations, print them out for patients, and maybe create expectations that's exactly what they'll get. We're with a group of patients that are looking at their face in their phones like never before. And creating sort of delivering on those expectations, I find very challenging. So how do we use technology? And more importantly, how do we integrate that technology in our planning to inform, to educate, to sort of work towards consensus, but also to leave with reasonable expectations of some of the variance of results that we see? I think that's something we need to spend more time talking about. I'd love to see more examples of people doing that well, talked about in meetings, because I think that's an art.
Yeah. I'm so excited you brought this up because I'm always curious about artificial intelligence, right? Yeah, I mean, I'm using it on a daily basis. And so where do you think that there's perhaps a role in artificial intelligence in either the care that you do, the research that you do, et cetera?
So some of the work we're doing right now at CHOP is really trying to use a lot of the data that we have acquired to better help drive that decision-making. Some of it can be timing of certain surgeries. Some of it can be looking at where patients are compared to normative images and maneuvers that will get them there. Some of it looks at actually their perception and how that may or may not connect to some of the objective measures. It also translates into surgical planning. And I think one of the divergences we typically have right now for, say, cranial surgery is, do we basically do things freehand and tend to overcorrect things that we think will kind of reduce back with age? Or do we use virtual surgical planning and really kind of model everything out, or some combination of the two? But probably all of us have seen examples of people that over-engineer with technology, but don't embrace those first principles of, say, accounting for growth. And you see a beautifully executed surgery with lots of assistant type sort of things, cutting guides, et cetera. And then you've met the patient, unfortunately, because they're relapsed and they've now come to you for a second opinion. And technology has, for the decision maker previously, replaced use of principles and judgment. We all know those cautionary tales. And so to me, the question is, how can we make those things augment? For instance, my guess is for breast reconstruction, for instance, there is a role for using artificial intelligence to help kind of anticipate certain shape, size, aging, et cetera. Same thing for the face. So we need to figure out how to use that more. We also have to translate bony movements often into things that will affect the soft tissue envelope. Yeah. And how to do that is not exactly precise, but we're now starting to amass the data that's helping us see that. And that's super cool because that's going to help us figure out those translation ratios in really 3 dimensions in ways that even calculations and kind of multipliers that we all learn in the textbooks don't quite work as well. So I'm excited to see how that unfolds.
What's one case that sticks out to you that is just super interesting and you like to tell it a lot to either residents or other people when you're out? Something that just sticks with you, whether it was just a fascinating story, an incredible reconstruction, or just a really emotional story.
I'll give you one that's emotional. So many great cases.
Oh gosh, I think I'm emotional. So
I think we all live through the emotion in particular, but a case that actually happened in Nicaragua. We were building our cleft program there, and we were starting to do orthognathic and craniofacial surgery. And we had very few supplies, and so we really carefully planned out, our approach. And we did a posterior vault distraction for a patient that had multi-suture craniosynostosis and had developed elevated intracranial pressure. And we were doing a posterior vault distraction surgery you guys know well. And we were on the table. We had done the coronal incision, peeled back the skin. We were just starting to cut the bone. And the anesthesiologist looked over and said, "We've lost the pulse." And we looked at the monitor, and sure enough, we had lost the pulse and the blood pressure is coming down. And, I go in training for craniofacial surgery. Of course, thinking of cranial surgery, I'm expecting either hemorrhage or air embolus as the most likely cause of hypovolemia or pulse. But we had just started cutting the cranium. So it was too early for either of those things, which is a really uncomfortable feeling when you feel like that training that you had suddenly requires a broader differential. And fortunately, as we built up that team, we had arranged for PALS training and really training everybody that was going to be in the room. Yeah. And as I am realizing I'm sort of stalling for a moment, one of the anesthesiologists said, "Look, I think there's peaked T waves." Somebody says, "Well, that's hyperkalemia, but we're not giving potassium." So as we flip the patient over to start doing CPR, they send to the labs. But on that observation, they started treating for hyperkalemia. And they pushed some glucagon and insulin and calcium. And we got some labs back a few minutes later, and sure enough, it was hyperkalemia. What had happened? Well, we were starting the blood transfusion as we do early in the vault surgery. And the blood, unfortunately, in Nicaragua was not fresh. It had been around for about 3.5 weeks, this particular bag. And so the intracellular potassium, because cell lysis was happening, was becoming extracellular. And so into this fragile 10-kilo baby, we were infusing a lethal dose of potassium. Obviously, despite all of the good planning, this happened. We quickly aborted the case, got her stabilized, did the case about a month later. But again, it was a great lesson for a few reasons. One, we need to be continuing to push the envelope to spread the fruits of what we can do to other places. Secondly, we got to do it as a team. We got to have respect for people in the room, realizing at those tough moments, it's those colleagues, it's those residents and fellows and anesthesiologists and nurses that we, invest our time in and they invest in us to try to work on this together. And then we got to just try to think beyond the ortho bullets of the 1 or 2 things that can cause things. Keep talking about the interesting cases, the unusual things, the zebras. And that's what I think makes us good physicians.
And talking about multidisciplinary care, I mean, there's multidisciplinary care in itself is figuring out what's happening to that patient. And what also makes that situation challenging is you're not at CHOP, you're overseas. And wow, that's a touching story.
Well, an obvious question for me as a resident is, first of all, I'm so honored to train at a place like Penn and CHOP under people like you guys. So incredible, so inspiring. Just to be a quarter of what you guys are would be incredible. But what's just some advice for someone who would want to pursue craniofacial surgery, or just advice as a resident in general? What are just some pieces of advice?
So the advice starts with work hard and jump into cases and be curious. Yeah. I don't think there's a more powerful motivator than curiosity about things. And I think it's one of the things that you and a lot of our residents have as a remarkable common denominator. And that's what drives you guys. And what's
I had it too.
It was a little bit faltering that year. But it's one of the things that I think like drives, that energy, those questions in the operating room and stuff like that. So that's one part of it. Craniofacial surgery is awesome. And I think, when I trained, there was this misconception of, there's no jobs and yada, yada, yada. That's changed a lot. So there's obviously a lot of branching out of craniofacial surgery to new elements like gender-affirming care, like the fact that there's a lot more different forms of craniofacial surgery happening. There's also a proliferation of children's hospitals and children's centers. And so there's a lot more of this care happening at different places. All fields evolve, as does ours. But it's a very, very exciting time to be part of craniofacial surgery.
Yeah. So I'm a resident. I'm a PGY1, let's say. You're co-director of the CHOP Craniofacial Fellowship, world-renowned program. And I want to do craniofacial surgery and I want to come to CHOP. What advice do you have for me?
Yeah. Well, it's an awesome fellowship, first of all. So you're looking in the right direction. I think one part is, being clinically well-rounded is important. As we talk today and we're talking about some of these cases, they're not just focused on cleft and craniofacial. They're all throughout the body and they touch on all aspects of plastic surgery. And so that's an important thing, is kind of continue to be broad. Develop an early spike and kind of seek it out and why. And certainly I think starting to do a little bit of research is important, not for the numbers, not for doing a quantity of research papers. It's to kind of learn the depth. I think that's what gets us excited about things, when we start to learn a little piece and then kind of let it grow. I think another part of it is learn to be a good clinician and a good technical surgeon. I think sometimes there is, with all of the many requirements of residents and, all of the demands from other healthcare personnel that are paging you and asking for orders and things like that, and doing some research and things like that, there can be an emphasis away from just putting in the reps.
Yeah.
When I was an intern, and I still tell this to our current interns, when I was an intern, even when I rotated on neurosurgery and orthopedics and all these other services, I tried to be there to open the incision of every first start case. And that meant I had to get into the hospital earlier to draft my progress notes. We did them in paper then. So they were ready to file as we rounded, because the assumption was you'd round as a team and the intern would go to the floor and start doing all the work.
Yeah.
And I said, no, in every case and every day, my goal is to start the incision. And for an abdominal case, maybe I'm just going to start the Whipple by making the incision down through the abdominal wall. And then in 30 minutes, I'm going to be dismissed to go to the floor and work notes. Yeah. Fine. But I want to be there every day. I also want to learn the problems of other teams. And that's been, to me, something that served me really well. My chair in Seattle, Nick Vetter, who just retired this month, was total legend. And one of the things that he always, told us is, you are here to be surgeon's surgeon. When you think of all the specialties of surgery, the intersection point should be plastic surgery. And to me, that was the magic of general surgery. You and I both share that when you learn what other people do, you learn their problems, you can start helping them see their problems. And I think that's remarkable. And so I think getting interns in, making those reps is important. It is, at the end of the day, an apprenticeship, because you got to learn this skill set. So those are some of the things.
Yeah, well, incredible. Wow, this was such a special episode.
Very awesome.
And I'm so happy that you were here to be here at FIGS, because this was I learned so much, and I think our audience is going to just find this fascinating. So thank you again, Dr. Swanson. This has been incredible. We do something fun. We just have some fun, short, rapid-fire questions we do at the end of every episode, just to wrap it up.
Yes. But this is an off-the-script.
Oh, okay.
Yeah,
Love it.
So, I will never take my kids over to his house. And the reason being is because I buy like a playset from Costco. What does he do? He builds a 2-story tree house. Is it 2 stories? Or is it 3?
A couple of stories, yeah.
How many? 2. With electricity.
With electricity?
So
you just need to hire him to make one at your house.
How long did it take you?
It was a bit of a COVID project. And it was actually done with a lot of my neighbors. Everybody kind of pitched in. It was pretty cool.
Got virtual surgical planning in there.
Yeah, right. It was a lot of fun. We wanted a place that like the kids could sleep out. I sometimes get sent out there when I misbehave. Little zip line running out of it and a slide coming down. But it's a fun little getaway.
That's amazing.
I gotta see that. In the OR, what music do you like? Like I know because I've been in the OR, but for our guests,
I love music. I know.
Yeah.
If you can't hear the pin drop. I love hip hop primarily. I love some EDM once in a while. I'm a big believer in music. So there was this study done about 20 years ago where they had a bunch of people put on headphones to listen to kind of like, a silent disco. Mm-hmm. And they had them hold beer mugs and dance with their beer mugs in the air. And they had one group that did it that were all listening to the same music. And then a different group doing it that were all listening to different music at the same time. And then they had each group do some tasks together. Okay. And the group that was in line with the music did way better on all their tasks. I feel the same way in the OR. Yeah. We're listening to good music. The nurses, the staff, everybody's into it. We all went to hear the DJ's two friends when they came to Philly in February. We took the whole CHOP OR
that's cool. Awesome.
to go hear them because we tend to listen to two friends a lot at the end of the day. And it was an awesome night.
We'll go with you next time.
Yeah. I think we still keep the vibes going.
Yeah. Also, what's your favorite surgical instrument?
That's easy. The Molt elevator. Okay. Sometimes called the Molt number 9 elevator.
I think
that's the first one.
Oh, well, the others are all misinformed because, it's a dental instrument. It's efficient on one side, kind of a broad beaver tail kind of spatula. On the other end, more aggressive, more pointy. But with that, you can do just about anything. I use it on almost every case. It's a remarkable instrument.
Yeah.
If you could play soccer for any team, what team would it be? Quickly.
Chelsea.
Okay.
Well, thank you again.
Yeah,
thank you, Figs.
This was awesome.
This was really cool.
Thank you, Dr. Swanson.
This is
I don't
great.
think there's anything else that
defines
awesome humans than this.
Thank you for listening to The DIEP End, a plastic surgery podcast. If you've enjoyed today's conversation, please like, subscribe, and leave a rating on Apple Music or Spotify. Video from the podcast is available on Instagram and YouTube at The DIEP End Podcast. Join us again soon for more conversations with luminaries and experts in the world of surgery.